Good morning, everyone. Welcome you all for today's session. We believe this will be one of your interesting session in this year. So, and also this is the first time we are taking psychiatric coding here in Abu Dhabi local chapter. So, hope you all will enjoy this session, and I believe that this will be more informative. And whoever do psychiatric coding, I believe this is going to help you in your daily life. Looking at the session slides, it has a lot of information, and I believe this will be helping you a lot. I request all of you to keep your mic in mute, and then have your questions later. You raise your hands at the end of the session. We can have a Q&A session, and at that time you can ask your questions. Also, no need to share your member ID in the group chat. We will be sharing with you a form at the end of the session. You can fill your forms, and you can give your IDs. Okay. So now I will introduce the speaker. She is one of our chapter officer. She is holding CPC, CCS, CDIP certifications, and basically she is a MBA healthcare management degree. She is having a MBA healthcare management degree. Uh, Totally, she is having around 8 years of UAE coding experience. She is one of the common, quite coder which we have seen in our past. So hopefully this session also will be very interesting, and also she is going to share her experience with us. So Teja, the stage is yours. Please go ahead.
Thank you, Mr. Sheikh, for the beautiful introduction about me. Good morning, everyone, and welcome. I am Tejaswi Geelakunta, CPC certified, and today I will be presenting psychiatric CPT coding guidelines. I am very happy to see you all here for this AAPC Abu Dhabi local chapter learning session. Today, my aim is to make psychiatry CPT coding practical, clear, and audit ready. Please keep this session interactive. Think about the claims, denials, approvals, and documentation gaps you will see in your daily work because we will connect the codes directly to real revenue cycle practice. Before we move into the detailed psychiatric CPT coding sessions, let us first review the learning objectives for today's sessions. By the end of this training, participants should have a clear understanding of the major psychiatric CPT code categories and how each category should be applied in day-to-day coding and billing practice. We will begin by looking at the key psychiatric services such as psychiatric diagnostic evaluations, psychotherapy, family therapy, group therapy, psychological testing, and health and behavioral assessment services. The goal is not only to recognize the codes, but also to understand when each code is appropriate based on the service actually provided. Another important objective is correct code selection. In psychiatric coding, many services may appear similar, but the billing requirements are different. For example, diagnostic evaluation is different from the psychotherapy. Psychotherapy with medical management is different from the psychotherapy alone. And testing services require clear time based documentation. This session will help participants understand those differences clearly. We will also focus on documentation requirement, accurate coding. Accurate coding cannot be supported without strong clinical documentation. The provided notes should clearly show the service performed, time when it applicable, patient participation, clinical indication, treatment provided, progress, and any special circumstances that support the selecting code. The key part of this session is learning how to differentiate between psychotherapy, diagnostic evaluation testing, and family therapy services. This is very important because incorrect code selection can lead us denials, audit findings, payer queries, or reimbursement recovery. We will also discuss common coding errors, billing issues. This includes using codes routinely without proper support, missing time documentation, billing add-on codes, using non-covered combination, or failing to meet payer requirements. In addition to this, we will review key compliance concepts such as NCCI edits, MUU limits, add-on code rules, and coding restrictions. Understanding these rules helps prevent billing errors before claims are submitted. Finally, we will strengthen coding accuracy through practical examples and case-based learning. The purpose of this training is not only to understand the guidelines but also to apply them confidently in real time coding scenarios. Overall, this session is designed to improve coding accuracy, support audit readiness, reduce denial risk, and improve compliance reimbursement outcomes for psychiatric services. This slide is our complete map for this session. Psychiatric coding becomes much easier when we organize the codes into service sets rather than looking at the isolated CPT numbers. We will move into step by step through the diagnostic evaluation, ENM, psychotherapy, interactive complexity, family therapy, crisis testing, health behavioral assessment and interventions, applied behavioral analysis, and other psychiatric services. For each group, I will focus on four questions. What was done? Who performed it? How much time was spent? And what documentation proves it? Now we are introducing the two psychiatric diagnostic evaluation codes, that is 90791 and 90792. At high level, both codes are used for the initial psychiatric diagnostic assessment, but the difference is the inclusion of medical services. 90791 is selected when the evaluation is diagnostic in nature and does not include medical services. When it comes to the 90792 is selected when the diagnostic evaluation includes medical services such as medical assessment, prescribing activity, examination, or lab related medical decision making. From a coding perspective, these codes are mutually exclusive. So only one diagnostic evaluation code should be reported per data service. This slide is just the overview. In the next slides, we will review 90791, 90792 separately, including their documentation requirements, provider rules, billing limitations, NCCI edits, and common audit risks. Now let us discuss CPT code 90791, Psychiatric Diagnostic Evaluation. Let us discuss about let us see the definition. Psychiatric diagnostic evaluation and integrated biopsychosocial assessment, including history, mental status examination, and recommendations. This evaluation may include communication with the family or the other source and review and ordering of the diagnostic studies. Use of 90791 appropriate for a initial diagnostic evaluation or reassessment. Let us see the documentation requirements. The physician must include the data service, chief complaints, and referral sources. Complete psychiatric history, past, including mental status examination, diagnosis, risk assessment, treatment recommendations, but does not provide medical services, such as prescribing medication, ordering labs, and managing medications. For documentation, the note should clearly include data service, chief complaints, and referral source. The provider should document complete psychiatric history, including past diagnosis, medications, hospitalization, suicidal attempts, chemical dependent history, family psychiatric history, social and developmental history. The mental status exam is very important. It should include observations such as mood, affect, speech, thought processes, orientation, insight, judgment, and suicidal or homicidal ideation. The diagnosis should be supported with symptoms, duration, severity, functional impairment. The treatment plan should include therapy recommendation, referral if needed, follow-up plan, and safety assessment. The key takeaway is 90791 requires strong psychiatric evaluation documentation but no medical service components. If medical management is documented, we should consider 90792 or an appropriate ENM code instead. We'll, come, we'll discuss about the billing restrictions. Psychiatric diagnostic evaluation should not report with the other psychiatric psychotherapy services such as 90832, 834, and 837 and psychotherapy crisis codes and cannot be in 90792 including in the medical services. And this code can be billed for the psychiatrist, social services, and other counseling services. Psychiatrists may use 90791 but 90792 preferred when medical services rendered. No minimum time requirement. Document comprehensively regardless. May be used for the reassessment, not only for the initial evaluation. 96127. Brief screening cannot be added on the same date of service. It is both mutually inclusive. NCC bundled. In this slide, important from the audit and denial prevention perspective. When building 90791, we must always verify whether any other services built on the same date is bundled, duplicative, or restricted by the payer policy. As a general rule, 90791 is a standalone psychiatric diagnostic evaluation code. However, 90785 interactive complexity may be reported along with 90791 when the documentation clearly supports qualifying communication complexity. So the key point is 90791 may be built with 90785 when medical necessity met, clearly documented, and it's allowed by payer policy. And psychiatric services we must need the peer authorization as per the patient SOP. Let us discuss CPT 90792 Psychiatric Diagnostic Evaluation with Medical Services. The definition is psychiatric diagnostic evaluation with medical services. All elements of 90791 plus medical services consist of medical activities such as performing additional elements of the physical examination, initial recommendation of the course, treatment, including prescribing of the medication, and documentation of the laboratory testing or diagnostic studies with results and interpretation. Documentation requirements. All elements of 90791 plus medical services documentation. Physical examination findings relevant to psychiatric care, neurological or cardiovascular. Medication initiated at intake. Drug name, dose, frequency, route, rationale. Laboratory orders with clinical justification. It may be example CBC, CMP, thyroid, drug screen, lithium. Diagnostic study results with the provided interpretation such as EEG, MRI, genetics test, any other. Initial pharmacological management and treatment monitoring parameters. Drug interaction assessment documented, patient education on the medication, evidence-based treatment approach identified for the future therapy sessions. Billing restrictions such as physician and prescribing psychologist only, not for the social workers and other counselors. Cannot bill in the same day of other psychiatric diagnostic service such as 90791, psychotherapy course 908322 to 90838, and psychiatric crisis. Medical services
Good
must be
morning.
actually
Excuse me. You speak too fast.
Sorry. Okay.
Thank you.
Thank you. Medical services must be actually performed, not anticipated. Prescribing medication alone is sufficient to upgrade from 90791 to 90792. Ordering labs without results at time of service still qualified. No minimum time requirement. Documentation complexity demonstrates medical services. 90863 pharmacological add-on is not appropriate for the psychiatrist. Use instead 90792 or ENM codes. 90792 as per the MUE edits we should use in the data service only 1 unit. This slide is transition point in the presentation. After understanding the 90791 and 90792, we need to ask an important practical question to ourselves. When should an initial psychiatric visit be coded as a diagnostic evaluation and when it be coded as an office or outpatient ENM service? This decision totally depends on the purpose of the encounter, level of medical decision making, and payer policy and documentation available in the record. On this slide, we are comparing psychiatric diagnostic evaluation codes 90791 and 90792 with ENM codes such as 99202 to 99205. Just here we are explaining, here we are checking the difference between when to use psychiatric diagnostic service and initial ENMs. Use both codes families can be used for a initial psychiatric visit, but the correct code choice depending on the scope of service documented. Use 90791 or 90792 when the visit is mainly for psychiatric diagnostic assessment. These codes are best when the provider is evaluating the patient's psychiatric history, mental status examination, diagnosis, risk, and treatment plan. Use ENM codes when the visit involves broader medical decision making, especially if the patient has multiple medical comorbidities, medication risk, complex management, or significant diagnostic and treatment decisions. So, this is a simple rule. Let us discuss the psychiatric diagnostic evaluation versus ENM. The visit psychiatric diagnostic codes evaluation 90791 and 90792 when to code best is that the visit is primarily psychiatric assessment and treatment planning. Documentation should focus psychiatry related. MDM role is very limited. There is no time limitation for this code and we should not use the psychotherapy as a add-on code along with the diagnostic services. And 90792 is additionally it's adding the include the medical services and all settings like IP, emergency services, outpatient. There is no code differences for the diagnostic services. We have to use only the 90791 or 90792. Let us check with the ENM requirements. When we can code the ENM services instead of 90 diagnostic services. When patients have the multiple medical comorbidities or significant decision making, documentation should support MDM level or total line. As we all know, in as per the coding manual, we should not consider the time for the ENM level, outpatient ENM level in the Abu Dhabi region. Just this is a requirement just I mentioned. And physiotherapy add-on code we can use along with the ENM codes. In each setting, we have the different codes. Inpatient, we have to use the inpatient E&M codes. Consultation code, separate set is there. Emergency services, we have the separate set of E&M codes. And outpatient, we have the separate set of E&M codes. The coding tip is if the visit is mainly psychiatric diagnostic evaluation, use 90791 or 90792. If the visit is medically complex and support MDM, use the appropriate ENM code. The final code should always be selected based on the what was performed and clearly documented in the medical record. On this slide, the main message is document the history and examination. Document the history and exam clearly, but not count the volume of history and exam to select the ENM level. The clinical reason for example, the chief complaint mentioned every visit we need the chief complaint, specific problem oriented medical necessity. Follow up for the worsening depression, despective of settling. Not just to mention the follow up for the visit. Doctor should specify follow-up for the worsening depression despite of the settling. Pertinent psychiatric and medical history. Past psychiatric medical surgical history, social and family psychiatric history, medication and allergy list, and psychiatric review of system as relevant to this encounter. Medically appropriate history and exam performed and documented when clinically indicated. The treating provider decides the extent. There is no fixed checklist to satisfy. Extent no longer count towards the level. The amount of history or exam does not yet factor into outpatient ENM code selection. Volume driven notes, signals, and outdated templates to auditors. And the history and examination should be medically appropriate. This means provider documents what is clinically needed for the patient. There is no fixed checklist for us. For outpatient ENM coding, the amount of history and exam no longer decide the code level. The level is selected mainly by medical decision making. As I discussed before, in Abu Dhabi framework, time is not used for the outpatient ENM level selection. For ENM with psychotherapy, ENM part must be selected by NDM and psychotherapy time must be documented separately. The same minutes cannot be counted twice, once for the ENM and again for the psychotherapy. The key takeaway is history and exam supports medical necessity, but MDM supports the ENM level. Document clearly, avoid copy paste volumes, and separate ENM from the psychotherapy. On this slide, we are looking at the mental status exam, commonly called a MSE. In psychiatry documentation, the MSE is very important because it shows providers' direct clinical observations during the encounter. The provider should not simply write MSE is normal. Instead, the note should describe the key areas such as patient appearance, behavior, attitude, speech, mood, affect, thought process, thought content, perception, cognition, insight, and judgment. For example, the good normal MSC statement would be patient is well groomed, appropriate, speech, cooperative, mood is ethnic, effect is appropriate, thought process is logical, no hallucinations or delusions, denies suicidal or homicidal ideation, alert and oriented, insight and judgment is intact. If there are abnormal findings, they should be clearly documented because they support the diagnosis and medical decision making. For example, depressive mood, flat effect, disorganized thought process, hallucinations, poor judgment, or suicidal ideation may support higher clinical risk. The key takeaway is MSc is not just a checklist. It is the clinical evidence that supports the psychiatric diagnostic, risk, risk assessment, treatment plan, and coding accuracy. On this slide, we are looking at the medical decision making or MDM table, which is the key factor for the selecting outpatient psychiatric ENM levels as per the 2021 guidelines. MDM is based on the three main elements: the patient problems, the data reviewed, and risk of the treatment and management. For psychiatry, the most important area is often risk, especially when medication management is involved. For example, starting, changing, counting, or stopping psychiatric medication usually supports moderate risk if it is clearly documented. Low risk, for example, new patient seen for adjustment disorder and referral to the therapist. Moderate risk, example, prescription of the drug management or diagnostic or treatment significantly limited by social determinants of the health. Management of the psychiatric medication, patient whose adherence to the treatment is impacted by homelessness. High risk examples, drug therapy requiring monitoring for the toxicity, decision regarding the hospitalization, management of clozamine, initiation of the lithium, consideration of the patient behavioral health management, admission. In this, the key point is do not select the ENM level based on the history and exam value. The note must clearly support the MDM level through the problems, data, and risk. The simple terms, the documentation should answer what is the problem, what did the provider review, what treatment decision or risk was managed during the visit. On this slide shows more elaboration about the risk. We are focusing on the risk element of medical decision making for psychiatry ENM coding. Risk is one of the three MDM elements along with the problems and data. To select ENM level, at least 2 out of 3 MDM elements must support the same level. In psychiatry, the risk level often depends on the treatment decision. For example, simple reassurance or sleep hygiene advice may support minimal risk. Continuing a stable medication without changes may support the low risk. The most common psychiatry level is moderate risk, especially when the provider starts, adjusts, titrates, stops, or manages a prescribing psychiatric medication. High risk is used for more serious situations such as active suicidal or homicidal ideation with plan, decision for the psychiatric hospitalization, or toxic drug monitoring such as lithium, clozapine, monoamine oxide inhibitor therapy. That key takeaway is document the risk decision clearly. Do not write the diagnosis, explain what treatment decision was made and why it matters in the clinically. Key rule is any prescription drug management like start, adjust, stop psychotropic we can consider as a moderate risk. It alone it supports the 99214 or 99204 when paired with the moderate problems or moderate data as a 2 out of 3 elements criteria. In this slide is a quick reference grid showing how different psychiatry services are matched with the correct CPT codes. The left side lists the type of psychiatric services such as diagnostic evaluation, psychotherapy by time, psychotherapy with medical management, interactive psychotherapy, and psychiatric consultation. Across the top, we have the related CPT codes. The X mark shows which code or code combination may apply for the specific service state. The main purpose of this slide is to help us understand that psychiatric coding is not selected randomly. It depends on the three key factors. First, what service was provided. For example, diagnostic evaluation without medical service is usually linked to 90791, while diagnostic evaluation with medical services is linked to 90792. Second, whether psychotherapy was provided and how much time was spent. The psychotherapy codes are selected based on time. 90832 for the 30 minutes, 90834 for 45 minutes, and 90837 for 60 minutes. Third, whether an add-on code is supported. For example, 90785 is used only when interactive complexity is clearly documented. It should not be added routinely. Similarly, psychotherapy add-on codes such as 90833, 90836, and 90838 are used with the ENM service when both medication management and psychotherapy are separately documented. This grid also shows that medication or pharmacologic management may be reported with the appropriate psychotherapy service when the payer or documentation rules allow. So, the key message in this slide is select psychiatric CPT codes based on the service type, time, medical involvement, and documented complexity. The grid helps identify valid combinations, but every code must be supported by clear clinical documentation to avoid denials or any audit risk. On this slide, I want the audience to understand overall flow of psychiatric coding. Before selecting any code, first identify type of service provided, whether it's evaluation, psychotherapy, family therapy, group therapy, crisis, or any add-on service. The main coding logic is simple. Service type first, time second, documentation always. The grid is useful as a quick reference, but final code selection should always be based on provider's documentation. Medical necessity, patient presence, session time, and whether the service was separate and identifiable. The key takeaway is do not code from the memory or from the appointment title. Code only when was actually performed, timed, and documented. This slide, the main message is that the node should clearly support medical decision making, not just contain a large amount of history or examination. For the audit defense, the provider should clearly document the patient problem status, such as recurrent major depressive disorder, whether it's moderate or worsening, name severity and trajectory, not just a depression. Don't inflate the data elements. And in the clinic, PHQ-9 is not a counter test. Count external records, unique tests, ordered or reviewed, or independent historians. Separate the medical necessity from a level. History plus HPI and MSc justify why treated. Problems, data, and risks justify the level build. Name the risk decision. Treatment started or adjusted or continued. We can consider as a moderate. Suicidal ideation assessment, hospitalization decision is a high risk. Extent of the history, exam, and level. Perform mental status examination history when clinically indicated, but it no longer drives a code selection. Volume signals are outdated note to auditors. Protect the psychotherapy add-on codes. ENM by MDM only. The same minutes cannot count towards the both ENM and psychotherapy add-on codes 90833, 836 and 838. The key takeaway is strong audit proof note clearly shows the diagnostic status, data reviewed, risk managed, and treatment decision made. Now we are moving into the individual psychotherapy section. Here we will discuss on psychotherapy coding based on session time, documentation, whether the service is standalone or combination with the ENM. The key point is psychotherapy must include a clear therapy focus, modality, patient response, progress, and exact time. As we go through this section, remember time drives psychotherapy code selection, but documentation supports medical necessity. On this slide, we are selecting psychotherapy codes based on two things, whether ENM is performed and the actual psychotherapy time. If the psychotherapy is provided without ENM, use the standalone psychotherapy codes based on the session duration, such as 90832, 90834, 90837. If psychotherapy is provided with a separate ENM service, use appropriate psychotherapy add-on codes with the ENM codes, such as 90833, 90836, and 90838. The key point is same therapy time range, different code family, standalone when there is no ENM, add-on when ENM is separately documented. On this slide, we are introducing the psychotherapy code set based on time. Psychotherapy CPT code selection depends on actual face-to-face therapy, minutes documented in the note. If the psychotherapy is provided less than 16 minutes, it's not be separately billable. If psychotherapy is provided 16 minutes with the ENM, only ENM is eligible to bill. Based on the documented time, we select the appropriate code range 16 minutes to 37 minutes, 90832 or 90833 add on ENM code. It's a 30 minutes unit code. 38 minutes to 52 minutes, 90834 and add on 90836. It's a code valid is 45 minutes unit code. 53 minutes or more supports the 60-minute code 90837 or add-on 90838. It's a 60-minute unit code. For extended services, we can call as a prolonged service such as 90 minutes or more. Prolonged service may apply, but before applying these codes, we must check the payer policy and documentation required and why it's medically necessary to prolong the service. The key point is we should not round up the time casually. The documented time must meet the correct threshold. In coming slides, we will discuss each psychotherapy code in detail, including documentation requirements, restrictions, and audit risk. The midpoint rule is clear. You must pass the midpoint of the time you need to bill it. A 15 minutes session reaches the 38 to 52 band, so it is billed 90834, not 90837, which needs 53 minutes be required. Billing the higher code, short of its threshold is top denied and it makes us audit triggers. For the CPT rules, coding aligned to UAE, DOH, and 2021 ENM guidelines. Prolonged ADAN 99354 applies where the framework really recognized it's verified the current payer policy and medically necessity and documentation requirements. Now let us look at the CPT code 90832, individual psychotherapy. The definition is psychotherapy with patient and or family member may include ongoing assessment, adjustment of the psychotherapeutic interventions, and involvement of the family members or others in the treatment process. The code is used when the provider performs psychotherapy with the patient, and it may also include family members when their involvement part of this treatment process. Think 90832 focus therapy session, short, structured, and goal oriented. The provider may address one main issue such as anxiety, coping, mood symptoms, stress management, behavioral activations, or supporting counseling. And documentation requirements, we must require the time-based course, start time and end time, exact clock times required, psychotherapy modality named cognitive behavioral therapy and DBT, ACT, CPT, EMDR, IPT, etc. Based on the patient condition, psychotherapist, psychologist can apply this course. Psychotherapy modality and frequency of treatment, diagnosis and relevant clinical conditions, presenting symptoms and treatment focus, functional status and impact on daily activities, focused on mental status examination findings, treatment plan, prognosis, patient response, and progress towards the therapeutic goals. When it comes to the restriction of this bill, code billing, bef- below 16 minutes of the face-to-face therapy, we cannot report the 90832. Cannot bill with the ENM codes. As we know, we have the separate set for the ENM add-on psychotherapy codes. Cannot bill as a same date of 90 psychiatric diagnostic services and crisis interventions. Cannot bill in the same date of psychotherapy extended codes such as 90834 and 90837. The key takeaway is 90832 focused psychotherapy, 16 to 37 minutes, supported by clear time and therapy documentation. Documentation of the goal time spent for the psychotherapy cannot be considered for the regulatory audits and also payer audits. Example, psychotherapy given for 30 minutes. It's not a valid documentation. Physician must document start time and end time for the separate columns. We can select the code based on the time duration of the psychotherapy. CPT code 90834 individual psychotherapy. The definition is psychotherapy with patient and or family member may include ongoing assessment, adjustment of the psychotherapeutic interventions, and involvement of the family members or others in the treatment process. 90834 requires 38 minutes to 52 minutes, so the documentation should shows deeper therapy session in addition to the basic 90832 documentation, and 90834 should include more details on specific psychotherapy techniques used, patient engagement during the session, symptom severity, and rating scale if applicable, connection between the psychotherapy session and the treatment plan, family member involvement if present. Also, we need start time and end time, exact clock times mandatory. Evidence-based treatment modalities specify the session specific techniques used. Symptom severity rating scales such as PHQ-9 and GAT7 and PCL file if applicable. Detailed patient engagement and therapeutic progress narrative is required. Connection to the treatment plan goals for the sessions and billing restrictions. Minimum 38 minutes required to report this code. Cannot bill with the ENM codes as we have the separate set codes for the ENM add-on codes. In the same date, we cannot code same psychotherapy 30 minutes and 60 minute course. Cannot bill with the psychiatric diagnostic evaluation such as 90791, 90792 and crisis intervention codes 90839. CPT code 90837 individual psychotherapy. The definition psychotherapy with patient and family member may include ongoing assessment, adjustment of the psychotherapeutic interventions, and involvement of the family members or others in the treatment process. This code is used when the provider performed an extended individual psychotherapy session with the patient. Family members or other involved individuals may also report participate when their involvement part of their patient treatment process. The service may include ongoing assessment, adjustment of the psychotherapy interventions, active therapeutic work based on the patient symptoms, emotional status, functional concerns, and treatment goals. For documentation, provider should clearly record start time and end time for the psychotherapy service. Since this is the time-based code, must support the session met the required duration, that is 60 minutes 90837. The clinical notes should include strong psychotherapy narrative. It should describe the patient presenting issues, therapeutic focus, intervention used, patient response, and progress towards the goals. For example, provider may document treatment for the depression, anxiety, trauma-related symptoms, behavioral concerns, grief, relationship stresses, or emotional regulation difficulties. The note should explain what was addressed during the session and why. A longer psychotherapy encounter was medically necessary. If specific evidence-based therapy, such as used CBT, DBT, or supportive psychotherapy, trauma focused psychotherapy, or family based intervention, the modality should be documented clearly. For EMDR structured therapies, the relevant treatment phase or therapeutic activity should be included when it applicable. The provider should document progress or barriers to progress. This may include involvement, improvement of coping skills, reduced emotional distress, better insight, improved functioning, or continued symptoms requiring ongoing therapy. For billing perspective, 90837 minimum time is required 53 minutes, and we cannot bill with the other psychiatric services such as 90838, 90832, or 90834, and diagnostic psychiatric evaluation codes and psychiatric crisis codes. Now let us look at psychotherapy session that extend to 90 minutes or more. This slide explains when prolonged service codes may be added to CPT 90837. Since 90837 already represent an extended individual psychotherapy session, any additional prolonged service must be clearly structured by the documentation, time, and clinical need. When the total psychotherapy time falls within the standard 90837 range, we should bill only the 90837 only. The slide shows that 53 to 89 minutes does not meet the prolonged service threshold. Once the session reaches 90 minutes, prolonged service coding may apply. For 90 to 134 minutes, the appropriate combination is 90837 and 99354. If the session continues furthermore from 135 to 164 minutes, then we report 90837 plus 90354 99354 plus 1 unit of 99355 additional unit. For 165 to 194 minutes, we report 90837 99354 plus 99355 into 2. 2 units of 99355. Let us look at the example. A patient with the post-traumatic stress disorder receives 105 minutes trauma-focused EMDR session. Documented start from 9 a.m. to 10:45. The first 60 minutes 90837. The next 45 minutes of prolonged time falls 9 to 134 band at 99354 as additional prolonged services. For audit protection, documentation must clearly shows the exact start time and end time, clinical reason for the extended service session, the therapy method used, the patient response or progress. The key point is prolonged psychotherapy should not be billed routinely. It must be supported by clear time, documentation, medical necessity, and payer policy. Now we move to psychotherapy add-on codes such as 90833, 90836, 90838. Formula is ENM code 992022 99215 plus add-on psychotherapy code combined encounter claim. Start time and end time must be documented for the psychotherapy and ENM time and psychotherapy time documented separately. The psychotherapy add-on codes follow the same documentation standards as their matching the standalone individual psychotherapy codes. The only additional requirements for the add-on codes is that it must be documentation must be separately identifiable. ENM service should be documented. This means provider must clearly document two separate services in the note. First, the ENM portion, such as medication management, clinical decision making, prescription changes, risk assessment, and treatment planning. And second, the psychotherapy portion, including therapy modality, therapy start time and end time, interventions used, patient response, and progress. The most important point is ENM time and psychotherapy time must be separate. The same minutes cannot be counted for the both service. Example, patient came 8 a.m. and patient left 8:30 a.m. In this scenario, either we have to bill 90832 or ENM service. Here, there is no separate timings we are mentioning to report the psychotherapy at add-on code 90833. For example, if the provider spent 20 minutes on medication management, and 30 minutes on cognitive behavioral therapy, the ENM service is reported separately and the 30 minutes of the psychotherapy supports 90833. The coding tip is adult psychotherapy code is requires the same therapy documentation as 90832, 834 and 90837. But with additional requirement is ENM service must be separately documented and medically necessary. And also the same billing restriction cannot use the individual psychotherapy codes on the same claim and cannot use the psychiatric crisis codes and other diagnostic services in the same date of service. On this slide, we are explaining how to build ENM with psychotherapy correctly. The most important rule is ENM and psychotherapy must be documented two separate services. Example scenario for the ENM note. In the ENM section, uh, clearly mention chief complaints, problems, risk, and safety. In the data, they mentioned GAD scores increased 16 to up to 12 last visit, and medication management drug dose settling from 50 mg to 75 mg after discussing the risk, benefits, and alternative with the patient. And safety measures, physician has documented patient denies current suicidal ideation or homicidal ideation plan or intent. Total ENM for this session, physician was spent 20 minutes. And here separately, identifiable psychotherapy notes was documented. Here modality was used, cognitive behavioral therapy CBT. The start time was mentioned 8 a.m. and end time is 8:30. His focus is cognitive restructuring of the anxiety-driven avoidance behavior, identified catastrophic thought patterns related to work performance, and interventions was taken, thought records, behavioral activations planning, graded exposure, hierarchy initiated. Patient response, engaged actively, identified one behavioral goal before the next session. Progress, moderate improvement in self-monitoring skills. In the claim, is eligible to 99214 and moderate complexity. It supports by increasing the medication dose, and time was mentioned and CBT was used. Here, 30 minutes code is applicable. Total time was spent 50 minutes. This is just for example. The psychotherapy session, and do not mix medication management and psychotherapy in one paragraph. The ENM decision and therapy intervention must be clearly separate and at the same time cannot be counted twice. Now we are moving to interactive complexity. CPT code 90785. This is an add-on code used when communication practice makes the psychiatric service more complex than usual. It may apply with ENM, psychotherapy, or group therapy services. When there are special communication challenges such as involvement of guardians, family conflicts, emotional communication barriers, or third party or legal involvement. The key point is 90785 is never built alone. It must be added to eligible primary service and must be clearly supported by documentation standards. On this slide, now we will discuss interactive complexity, which means we'll see the definition. Interactive complexity captures specific communication factors that complicate the delivery of psychiatric service, requiring additional time, skill, and clinical staff effort beyond routine care. It is reported in addition to primary service code, never on its own. The eligible primary codes to code additional 90795, we can code 90785 along with the diagnostic evaluation codes that is such as 90791, 90792, individual psychotherapy codes 90832, 90833, 90834, 90836, 90837, 90838. Group psychotherapy 90853. For billing 90785, we need the minimum four qualifying criteria. At least one must be present to report 90785. First, maladaptive patient communication. This means patient behavior makes communication difficult, such as panic, yelling, severe agitation, repeated interruptions, or difficulty cooperating during the session. Second, caregiver emotional complexity. This happens when the parent, spouse, guardian, or caregiver is very anxious, angry, distressed, or repeatedly interrupt the session, making the encounter more difficult to manage. Third, sentinel event or mandatory reporting. This applies when there is abuse, neglect, safety concern, or any situation requiring mandatory reporting or special safety actions. Fourth, use of play or communication aids. This is used when normal verbal communication is not possible and the provider needs toys, picture boards, assistive devices, or other methods to communicate with the patients. Only one qualifying criteria is needed to report 90785, but it must be clearly documented in the medical record. The key point is do not bill 90785 just because the patient is child or emotional or the family is present. The note must clearly explain what communication difficulty occurred and how it is complicated the psychiatric service. Let us look at the common errors and audit triggers for the interactive complexity code 90785. As we discussed already documentation standards, I am not repeating again. I am going directly to the common errors and audit triggers. The first audit concern is using 90785 routinely on every psychiatric claim. This is a major red flag. It should only be added when qualifying communication complexity is clearly documented. The second documentation concern is vague wording, like statements like patient was anxious or patient was session was complex are not enough. The provider must document specific reason why communication was difficult, how it affects the service. Third, always verify provider and payer rules because coverage may different to each insurance company. Fourth, remember that 90785 is an add-on code. It cannot be built alone. A valid primary service code must be built on the same claim. Fifth, do not add 90785 with crisis codes 90839 and 90840 because crisis codes already includes high complexity service effort. Finally, the mandated reporting, the note must show actual reportable event, not just a general trauma history or routine risk discussion. The key point is 9078 by 785 must be supported by clear qualifying reason, valid primary code, and payer specific billing rules. Now we are moving Now we are moving to family and group therapy. In this section, we will discuss services where treatment involves the patient family, caregivers, or group setting. The definition, family therapy definition and scope. Definition, a specialized approach addressing how family relationships, communication patterns, and dynamic affect the patient mental health, aiming to improve family functioning and support the patient treatment goals. In the family therapy, who may participate? Family therapy may include family members, spouses, or partners, guardians, or other individuals significant to the patient care and treatment, not limited to blood relatives. The defining requirement is that each participant has a relationship relevant to the patient's psychiatric treatment. We have the two types of family therapy codes 90846 and 90847. 90846 is a family therapy without the patient present. Treatment is directed at the identified patient even when absent. 90847 family psychotherapy with the patient present conjoined. We, we can also call as a couple therapy. On this slide, we are discussing family psychotherapy, specifically when the patient is present or not present. The key difference is patient presence. Documentation should clearly include who attended the session and the start time and end time of the session, presenting problems or focus of the session and diagnosis, interventions used, family dynamics observed, progress towards the treatment goals, plan for the future sessions, clinical rationale for family-based intervention, how the family therapy is expected to improve the patient condition. Coding tip, you can build both CPT code 90832 90838, individual psychotherapy plus interactive complexity along with the family psychotherapy codes on the same day, but only if the key difference is separate and distinct service with appropriate documentation is required. On this slide, we are discussing group psychotherapy services and multiple family therapy group. The key difference is type of group. One service is multiple family group therapy where several families participate together. The other is group psychotherapy where the unrelated patients are treated together in one therapeutic group. For documentation, the provider should clearly document the session date, start time and end time, group topic, number of participants, diagnosis, patient participation, intervention provided, and progress towards the treatment goals. For group psychotherapy, each patient must have a individualized note even though they attended the same group session. Documentation must clearly include for the group therapy, start time and end time, diagnosis for the patient, and total participant was participated, key clinical issues discussed, individual patient response and participation, link between group activity and treatment goals. For the family therapy, multiple family group therapy, restriction is report once per family, not per the participants. Multiple families in the same room simultaneously cannot build group therapy together with the multiple family groups. For the group therapy, if any interactive complexity is provided, we can report 90785 as additional. Now we are moving to section 6 crisis, psychotherapy, and psychoanalysis. On this slide, we are discussing crisis psychotherapy. These codes are used only for high acuity psychiatric crisis situation where the patient needs immediate psychological, standardized stabilization and safety interventions. Example include acute suicidal ideation with plan or intent, homicidal ideation, severe panic, acute psychosis, acute psychosis, trauma-related crisis, or any life-threatening emotional crisis requiring urgent intervention. The documentation must clearly show the crisis situation, complete mental status exam, specific crisis intervention, safety planning, resource mobilization, treatment plan, and exact start time and end time. A very important building point is the crisis psychotherapy course or standalone course. They should not be built on the same day of diagnostic evaluation or individual psychotherapy or other psychiatric services. The key point is crisis coding requires urgent clinical risk, immediate intervention, exact time, and strong safety documentation. On this slide, we are reviewing an example of documentation that supports crisis psychotherapy. Patient presented with acute suicidal ideation with plan and intent following the job loss. Session begins 2:15 p.m. ended in 3:20 p.m. 65 minutes total time was spent. Mental status exam revealed severe depression, psychomotor agitation, and concrete suicidal plan. Crisis intervention include safety planning, removal of means, activation of the support system, and establishing 24-hour safety watch with the patient's spouse. Patient contracted for the safety and agreed to emergency department evaluation if ideation intensified. Follow-up schedule for the following monitor. Here we will see the how it's met for the 90839 criteria. The crisis situation is acute suicidal ideation with plan and intent following the job loss. The mental status examination, severe depression, psychomotor agitation, and concrete plan. Crisis intervention, safety planning, removal of the means, support system, and action. Resource mobilization, 24-hour safety watch with spouse, emergency department evaluation agreed. Treatment plan was safety contract and follow-up schedule for the next session. Time documented, start time 2:15 p.m. and time is 3:20 p.m. Total time was spent 65 minutes. Qualifies for the 90839. The key point is crisis note must clearly shows the crisis, risk assessment, interventions, safety plan, resources used, follow-up plan, and exact time. On this slide, we are discussing CPT 90845, that is psychoanalysis. The definition is a distinct analytic modality, free association, deep interpretation, transference analysis, reported per session with no time trials. It is a different from routine psychotherapy because it uses the techniques such as free association, dream interpretation, and transference analysis. Documentation should clearly shows the patient presenting problems, analytic focus, major theme discussed, transference or counter-transference observation, and dream material if applicable. This code is reported per session with a 1 unit per data service. The key point is 90845 should be used only when true psychoanalysis is performed, clearly documented, not for the general psychotherapy session. Now we are moving to other psychiatric services. In this section, we will briefly review specialized psychiatric codes such as ECT, biofeedback therapy, hypnotherapy, record evaluation, interpretation of the results, and report preparation. These services are not routine psychotherapy codes, so documentation must clearly support the specific service provided. Clinical indication, provider role, time if applicable, the payer requirements. The key point is use these codes only when the service is separately performed, medically necessary, and clearly documented according to the billing rules. On this slide, we are reviewing other psychiatric treatment services which are different from the routine psychotherapy. This includes ECT, biofeedback, and hypnotherapy. Each service must be supported by clear clinical indication and specific documentation. For ECT, the documentation and restrictions, documentation requirement, informed consent, pre-ECT evaluation, vital signs monitoring, is there any seizures, characteristics, post-ictal status, treatment number in series. It only bill for physicians if report anesthesia is performed. Payer authorization is based on the payer requirement. We can bill only one unit for the data service. Individual psychophysiological therapy. Documentation restrictions is biofeedback modality used, EMG thermal, EEG, neurofeedback, psychotherapy content, patient response session duration, and clock times. It's required face to face, and we have to check payer requirement as per our internal contract, and we have to use only one unit in the data service. And 90875 876 is the additional code for the individual psychosocial therapy and hypnotherapy. In the hypnotherapy, clinical documentation, clinical indication, induction technique which is used, suggestion made during the trance, depth of the hypnosis, post-session response, connection to treatment and goals. And we have to check the coverage limit as per the payer requirement, and we have to use only one unit in the data service. This course requires service specific documentation, payer verification, and clear medical necessity before billing. On this slide, we are reviewing records and reporting related psychiatric services. These codes are used when the provider performs activities such as reviewing psychiatric hospital records, explaining psychiatric results to the family, or responsible person, or preparing the psychiatric report. The documentation must clearly shows what record were reviewed, who was performed, was explained to, why the service was medically necessary, and what report or recommendation was prepared. These services are not routine psychotherapy or ENM service, so payer coverage may vary for each insurance. The key point is bill these codes only when the service is separately performed, clearly documented, and not part of any other routine psychiatric service. Now we are moving forward psychological and neuropsychological testing services. In this section, we will discuss testing related codes including evaluation, test administration, scoring, developmental testing, and neurobehavioral status examination. The main focus is to understand the difference between professional evaluation work and test administration work. Key recommendations and final reports. Testing codes are highly documentation driven, need medical necessity, time, test names, interpretation, and report must be clearly recorded.
Hello.
On this slide,
Yes, ma'am.
we are looking at the complex family of psychological and neuropsychological testing codes. The main purpose is to understand that testing services are divided by type of work and who performs the service. Some codes are professional evaluation, where the physician or qualified provider interprets the results, make the clinical decision, prepares the report, and gives feedback.
No need to let
Psychological
let
evaluation,
option
in the
code.
category level, first block is psychological evaluation,
Yeah, please.
that is 96130 and add-on code 96131. It's a first hour plus each additional hour. It can be performed by physician or qualified healthcare professional. It's only for the evaluation codes. Neuropsychological evaluation, that is 96132 and add-on code 96133. It's the first hour code for 96132 and each additional hour is 96133. It can be performed by physician or qualified healthcare professional. It's a neuropsychological evaluation reporting purpose only. Administration and scoring. It's a professional code, that is 96136 and 96137. Time required, first code is 30 minutes and each additional 30 minutes 96137. It can be done by physician or qualified healthcare professional. It's the administration codes. Admin and scoring codes by technician 96138 and 96139. It's reporting first initial code is 30 minutes and each additional 30 minutes is 96139. It's a technician course in administration reporting purpose only. Developmental testing 96112 or 96113. It's a first hour code and each additional 30 minutes. It can be done by physician or qualified healthcare professional. It's an administration and interpretation included in this course set. Neurobehavioral status exam 96116 and 96121, first hour and each additional hour. Physician or qualified healthcare professional, it's a cognitive examination. Automated test plus results 96146. Once per session, it's an electronic platform and automated only. Brief emotional behavior code is 96127. It's we will use for the per instrument and we can use max 2 codes for data service. It can be done by staff or clinician. It's a brief screening. The key point is do not mix evaluation time and administration time. Each code family. Each code family represent different work, different time units, and different documentation requirements. Always before coding, we have to check what testing was done, who performed it, how much time was spent, was interpretation and report documented. On this slide, key distinction is between evaluation work and administration work. Evaluation is provided clinical thinking. It includes interpreting the test results, forming the diagnosis, making treatment decisions, writing the report, and giving feedback. That is 96130, 96131, and 96132 and 96133. Administration is the testing process itself. It includes giving the test, scoring the responses, and recording the raw results. This important may be done by professional or technician. We have the two kind of courses here: professional work and technician work. It's not include the interpretation and evaluation work. Confusing the two, billing interpretation time inside administration course or administration time inside evaluation course. Keep them mentally and on the claim as a separate parallel service. They are frequently billed together on the same episode because the technician and qualified healthcare professional administrator while the psychologist is interprets the each capturing different work and different time. Testing documentation must be fully supported by medical necessity. It includes relevant history, examination, results of the pertinent diagnostics test, and specifically any suspected mental illness or neuropsychological abnormality or CNS dysfunction. The initial clinical findings that establish the need for the testing. The type of testing is indicated, time involved, and whether initial testing or it's a follow-up test. Previous testing, same or different providers, and efforts to obtain those results. The test is administered with scoring and interpretation. Treatment recommendations and diagnosis and recommendation. The medical record and the assessment report must document the diagnosis and the treatment recommendations. It should be the medical record should be legible, signed, and retained. Documentation must be legible, signed, and kept in the patient records and available in the regular on request. If the test is more than 8 hours, it must be justify the medical necessity for extending this test. Report must be generated. Administration of the testing must produce the material that formulated into report provided to the referring provider. On this slide, we are discussing psychological testing evaluation services. 96130 is the first hour code. 96131 is each additional hour. Psychological testing evaluation, integration of the patient data, interpretation of the results, clinical decision making, treatment planning, report generation, and interactive feedback to patient and family. Not for the administration of the test scores. The common test is a MMPI 2, MMPI adult code, and patient personal assistant intervention, MCMI 4th division, and WAIS 4th standard BNet, Beck depression, anxiety inventory, Rosage, and TAT, ADHD, or autism evaluations. The documentation should include medical necessity, reason, symptoms, and differentiate. Each test should be reviewed, interpretation, clinical significance, diagnosis, treatment recommendations, formal report, and feedback session. Total professional time is required in the documentation required. What 96130 pays for? The psychologist brain, it is we can consider as a psychologist is a brain interpretation, diagnostic formulation, clinical decision making, treatment planning, report writing, and feedback. Test is administered is billed separately. 96136 and 96138 is a we can report based on it's a professional done or any technician done based on the administration codes and documentation. On this slide, we are discussing neuropsychological testing evaluation services. These codes are used when the provider evaluates the relationship between brain function and behavior. The definition 96132 we can report as a first hour code and 96133 each additional hour. Neuropsychological testing evaluation, integration of the patient data, interpretation of the standardized results, clinical decision making, treatment planning, report generation, and feedback. It's a brain behavior focused test, especially for the conditions such as dementia, Alzheimer's disease, traumatic brain injury, stroke, epilepsy, memory problems, and other cognitive disorders. Common neurological tests may include Wilshire memory scales, brains, trial making test, Wiscon card, sorting test, Boston naming test, stroke test, Ray complex figure test, digit span, verbal fluency test, and other memory or executive function batteries. These tests assess important domains such as memory, attention, language, execution verb function, processing speed, and problem solving ability. The documentation should clearly include the reason for test, test review, interpretation, clinical findings, diagnosis, treatment recommendation, formal report, feedback session, and total professional evaluation time. 96132 and 96133 are for the neuropsychological interpretation, clinical decision making, report writing, and feedback, not for the test administration itself. On this slide, we are looking at the test administration and related testing codes services. The first point is separate administration and scoring from the evaluation. These codes are used when the test is actually administered, scored, raw results are recorded. They do not include the interpretation, diagnosis, or report writing. First, 30 minutes 96136 plus each additional 30 minutes 96137 includes face-to-face computer-assisted administration, scoring, recording results only. For the interpretation, diagnosis, and reports, we should report additionally 96130, 96133, 96130 96133. For the technician course, the first 30 minutes 96138 plus each additional 30 minutes score 96139. It's done by technician under supervision of psychometrist or psychology technician. Document supervising the provider, technician name, test administrator, time spent. The developmental testing 96112 and 96113. The first hour 96112 plus each additional 30 minutes 96113 used for autism used documentation
Teja, you can unmute your mic actually. I muted all. Just unmute your mic, Teja. I mute for all because somebody was talking.
sorry for the interruption. And the developmental testing first hour 96112 plus each additional 30 minutes 96113 we may report. It is used for conditions like autism, developmental delay, cognitive development concerns, and behavioral assessment. The code should include developmental history, tools used, interpretation, diagnosis, and recommendations. Most frequently, this test we used for children's. For the neurobehavioral status examination, codes are 96116 plus 96121. First hour, we may report 96116 for each additional hour 96121. Provider assess the cognition, memory, attention, thinking, judgment, reasoning, and executive function. Documentation should include mental status findings, cognitive assessments, clinical impression, and recommendation. The key point is administration codes capture testing work, while evaluation codes capture interpretation and clinical decision making. Keep the time and documentation is separate. On this slide, we are reviewing two practical testing building examples. In this first example, neuropsychological evaluation includes records, interpretation, analysis, report writing, and feedback. The test was performed WAIS 4 and MMPI-2 Corners ADHD scale. For the reviewing of records, qualified healthcare professional spent 15 minutes, interpretation 20 minutes, analysis 15 minutes, reporting 20 minutes, for the feedback 15 minutes. Total time spent 85 minutes. So it's qualified to be 96130 plus 96131. And neuropsychological evaluation, technician plus professional. The technician administration and scoring 96138 into 1 and 96139 into 3. Psychosocial interpretation 96131 and 96133 into 2. Administration technician interpretation reports feedback neuropsychologist. The common compliance neuropsychological bill. The pattern is administration course 96136 to 96139 and evaluation course 96130 to 96131 are built together. The technician qualified administration, the psychologist's interpretation, each captures different work and different time. Okay. On this slide, we are discussing CPT code 96146. It is a automated testing in the single instrument. As per the MBA description, psychological or neurological test administration with single automated standardized instrument via electronic platform with automated results only. The documentation requirement, single automated instrument via electronic platform. Automated results generated. There is no human scoring. Its results generated by automatically by the machine. Platforms and instruments name recorded. If any qualified healthcare professional interprets the results, we can bill additionally 96130 and 96132 separately. Restrictions and edits. As per the MUA edits, we can bill 1 unit per data service with along with 96136 or 96138 same data service. Cannot bill along with psychiatric diagnostic evaluation codes such as 90791, 90792 on same data service. Cannot bill with psychotherapy codes such as 90832 to 90838. If the person administered the test do not use the 96146, we can use 96136 to 96138, or if it is big test, we can use 96127. On this slide, we are reviewing practical example for 96146. Automatic testing. Here the patient completes computer administered cognitive screening test on the tablet. The key point is the platform generates the automated scores. There is no human administration or scoring. So 96146 reported once per session for the automated test and automated results. If the psychologist later reviews, interprets the results as a part of broader evaluation, is not included in the 96146. It should be documented separately under the appropriate professional evaluation service. From audit perspectives, do not report 96136 or 96138 with the 96146 because those codes for the human administration. Also, documented platform name, instrument name, automated results, and whether separate interpretation was performed. The key point is 96146 for automated testing, human interpretation if medically necessary, and documented is separate. On this slide, we are discussing CPT 96127, which is used for brief emotional behavioral assessment using a standardized screening tool. This code is reported per instrument, and documentation should clearly include name of the tool, the score, and the date, and the brief clinical interpretation. The common examples include PHQ 9, GAD 7, Audit C, DAST, PCL5, Garner, Vanderbilt, and Columbia Suicide Severity Rating Scale. The important restriction is that 96127 cannot be built on the same data, psychiatric diagnostic evaluation, psychotherapy codes, and automatic testing codes when bundled by the NCCI rules. Key point is 96127 is for the brief screening only, not fully psychological evaluation. Each building unit must have a named instrument, score, and documentation instrumentation. And as per the MUA edits, it is built in the data service only 2 units, up to 2 units. This is for worked example. During a pediatric visit, staff administrated and scored the HQ9 and Vanderbilt ADHD scale. Each is a separate standardized instrument with a documented score, date, and clinical interpretation. No psychotherapy or intake is built that day. How we can report this score? 96127 into 2 units per instrument. 1 unit per the instrument. Unit 1 is PHQ9 and Unit 2 is a Vanderbilt ADHD scale. As we discussed before, we should not be report with the psychiatric diagnostic evaluation course and automatic test 96146. Only max we can use 2 units per day in the date of service. This slide is now we are moving to health behavioral assessment and intervention, also called HBAI. This section focuses on behavior, emotional, cognitive, or social factors that affects patient physical medical condition such as diabetes, cardiac disease, chronic pain, obesity, cancer, and other chronic illnesses. The important point is that the HBAI is not used to treat primary mental health diagnosis. It is used when the behavior changes supports the management of the medical conditions. As we go through this session, focus on 3 questions. What is the physical condition? What behavior factors is affecting it? What assessment or interventions was provided? The key point is medical diagnosis first, behavior focused intervention is second, and clear documentation is always. On this slide, we are discussing health behavioral assessment and intervention. HBAI is used when behavioral, emotional, cognitive, or social factors affecting the patient physical medical conditions. Example includes diabetic medication, adherence to lifestyle changes for the heart disease, coping skills for the chronic pain, stress related to the cancer treatment, or weight management barriers in obesity. These scores are not only used to treat the depression, anxiety, or post traumatic stress disorder directly. If the main treatment is for the mental health provider, psychotherapy code should be reported. Here we have the 5 code categories in this section. 96156 is assessment and also the reassessment, and 96158 and 96159 is the individual session. 96164 and 9615165 is a group session, and 96167 and 96168 is a family with the patient present. 96170 and 96171 is a family with the patient absent. As I discussed clinical examples, it's a diabetes, we can consider like medication adherence, heart disease, lifestyle changes, chronic pain, coping skills, and cancer, stress and compliance, obesity, weight management barriers. Primary DX should be physical or medical condition. Focus on behavior, emotional, and social impact. Document Medical diagnosis. Behavioral factors affecting the condition. Assessment and intervention provided. Patient family, patient or family participation. Time spent. Time based on the scores. This is the requirement for the documentation. Not for the primary. This course is not designed for primary mental health diagnosis. Generally not used to treat primary mental health diagnosis such as medical major depression disorder, generalized anxiety disorder, and post-traumatic stress disorder. If it is primary, we have to go for the individual psychotherapy or end up with the additional psychotherapy course or family therapy or group therapy according to the session if it is psychiatric conditions are the primary. On this slide, we are reviewing health behavior assessment and intervention course. This slide shows the HBAI family from 96156 to 96171. Rule is one simple. It's a medical condition is the primary diagnosis. And for the F course is the secondary diagnosis. Beha- Behavioral factors affecting that medical conditions are the focusing, not the primary mental health diagnosis. And code 96156 is assessment or reassessment. And documentation requirement is primary medical diagnosis documented, that is diabetes, chronic health, chronic heart failure, chronic pain, cancer. It is behavioral. What is the affecting to the on the patient because of the medical condition such as behavioral or emotional, social factors affecting the medical condition. What are the tools were used and cannot be with the individual therapy and HBA course on the same day, and as per the MUI edits, only one unit is eligible. In the same all remaining all codes are in the same rules. What are the medical condition is affecting and who are the whether it's individual intervention or group intervention or family intervention with patient or family intervention without the patient without the patient present, and documentation is clear and restrictions are the same. On this slide, we are reviewing adaptive behavior services commonly linked with applied behavior analysis or ABA course. These courses are mainly used for the structured behavioral assessment and treatment services, often for the patient with autism spectrum disorders or behavioral development concerns. The important point is that all courses are time-based, reported per 15 minutes per unit. Course selection depends on the three key factors: who performed the service, whether it was assessment or treatment, and whether it was provided to the individual or group or family or caregiver. Some services are provided by physician or qualified healthcare professional, while others may be reported by technician under supervision. Documentation should clearly show patient behavior concerns, assessment findings, treatment protocols, goals, caregiver involvement, provider type, supervision when applicable, and total time spent. This service structure slide helps simplify ABA coding. Selection of the code based on whether physician or qualified healthcare provider, professional provider, or technician or technician provider. Group therapy course require documentation of the how many patients were participated in the session. Each code is a 15 minutes time rule, and if it is evaluation provided by the healthcare professional, for example 97151 for the 1 hour, It is qualified for the 4 unit of 97151. This is the documentation requirement as I discussed earlier. Here, IB assessment report. The report should clearly including the referring provider information, assessment start time and end time, reason for the assessment. It should also document the patient behavioral history, prior diagnosis, previous evaluation, and interventions already tried, standardized assessment tools, scores, and clinical interpretation. Caregiver interview findings, functional behavior assessment components, and skill acquisition data should also be included when applicable. Finally, the report must include clinical impressions, clear medical necessity statement, and treatment recommendation directly linked to the assessment findings. ABA documentation must prove why therapy is needed, what behaviors were assessed, what data supports the plan, and how the recommended treatment addressed patient needs. This is the ABA documentation. I divide the requirement into assessment, treatment, time, family guidance. The assessment documentation should include tools, observations, data analysis, and the plan. Treatment documentation should show target behaviors, interventions, patient response, progress, any protocol modifications. Family guidance should document caregivers present, training provided, goal addressed, and how caregiver participation supports the patient behavior and plan. This is exclusions and edit slide compliance warning. Adaptive behavior codes should not be reported with the psychological or neurological testing codes when they are mutually exclusive for the same encounter, such as 961302, 96146. Also excluded 96105, 96110 developmental codes and other psychiatric screening codes in the same data service. And add-on and group codes cannot be standalone. Technician delivered service must be separate from the physician or qualified healthcare delivered services. Also, ASD diagnostic assessment is usually reported with the appropriate ENM service code, not ABA assessment codes, when it's provided by the physician. Psychiatric coding adjudication rules. So overall, no ENM time factor. Time cannot be used to select the ENM level in Abu Dhabi per the adjudication rules. Select the ENM level based on medical decision making only. Modifiers is not applicable. Modifiers are not applicable for psychiatric visits. Report the service codes as defined without appending the modifiers. For the modifiers like 24, 25, and 52, we cannot be coded for the psychiatric visits. Time-based codes start and end time. All time-based codes requires a documentation start time and end time. And the midpoint rule must be applied to assign the correct code. Physician reportable codes 90792 and 90845 are reported by physician only. Other psychotherapy service follows the provider's license and scope of service. Always code within the rendering provider's scope of practice as defined by the regulator. The service must match the provider credentials. These are the common denials in the psychiatry and behavioral health. The first group is authorization related. Like as we know, as per the depending on the payer, we have the certain guidelines. It's a pre-approval is required by the psychiatric psychiatric services. We must obtain before rendering the services. And authorization 005 claim information is inconsistent with the pre-certified authorized services. Example, we have received some of the denials. Approval we were obtained for the 30 minutes code, but psychologist provided the 90834 and we billed and submitted without checking the approval. In these scenarios, we received the authorization 005 claim. Claim 012 submission not compliant with the contractual agreement between payer and provider. And add-on psychotherapy codes, it must be built with the initial example. This is the one case, ENM or initial CPT code. Class 16, incorrect billing regime. This is diagnostic exclusion. Examples, major diagnostic disorders. We cannot bill with the bipolar or schizophrenia. Or unspecified anxiety with panic disorder, we may lead to get the class 016 denials. Clay 017 service are not available on the direct billing. Some of the patients we have the only reimbursement benefits, but we bill directly without checking the patient schedule of benefits whether it's reimbursement or direct billing. So in this scenario, we receive the reimbursed benefits only denial code. Code 010. Code 010. Activity diagnosis inconsistent with the clinician and specialty. Some of the, just example for this case, some of the denials we were received, psychiatrist referred to the occupational therapy with modality was used 97110. As per the rules, 97110 therapeutic activities should be referred by rehabilitation physician or neurosurgeon or orthopedician. So, in this scenario, when psychiatrist was referred, we received this denial code. Code 014. Activity diagnosis inconsistent with the patient age and gender. Mental behavior F53 series. The example for this case, F53 mental behavioral associated with the purpurium codes coded for the male patient. In this scenario, gender was different. Gender restricted codes used for the male patient. MNEC 003. Service was not clinically indicated based on the good clinical practice. Example, IQ test and neurodeveloping test was built without supporting diagnosis. And interactive complex, another example is interactive complexity we coded um, without supportive diagnosis like depression, anxiety, or panic disorder. What are the communication difficulties encountered during the session? It must be medically necessary. We should be required to document. MNEC 004 not clinically indicated without additional supporting diagnosis or activities. Psychological testing built with no corresponding behavioral health diagnosis. MNEC 005 service supply may be appropriate but too frequent. ABA therapy codes we used beyond the approved cap for monthly cap units. And some of the HB in the when patient on lithium or any psychotropic drug treatment, in that scenario, routine labs were due for the patients. In that scenario, if any HbA1c or any hyper lipid profile were performed frequently without the time limit, we may receive this denial code. Not covered not covered 001. Diagnoses are not covered. No psychiatric benefits on the patient plan, but we have accepted the patient as without checking the patient SOB. In this scenario, we receive this denial codes. Not covered 003. This codes service is not covered. We received this is the one of the Abu Dhabi payer. Um, Suppose family therapy, we require the approval, but we may build directly without taking approval. In this scenario, we are receiving this kind of demands like not service, not covered service. But if we take the approval, we may get paid. 5002. Payment is included in the allowance for another service. Psychotherapy plus brief screening was billed in the same claim, which is mutually exclusive and we cannot bill report on the same data service. Thank you all. I want to summarize the whole session into four compliance principles. First, select the correct code family. Second, document and medical necessity. Third, document time, provider role, participant whenever required. Fourth, verify DOH, demand, payer, NCCI ages, MUE, and authorization rules before billing. If we allow these principles, we reduce denials, improve audit readiness, and support accurate reimbursement.
Thank you. Thank you.
Hi,
Yeah, who is this?
hi, sorry.
Yeah, fine.
Because I can you add me in the chat because I cannot see all the chat. So when you send the form, I cannot see it.
We will present the QR code now.
Okay,
Okay, thank you.
thank
Thank
you.
you, Teja. Thank you for this session, and I would like to share the speaker certificate on behalf of all of our members.